European Health Management Association webinar, and we hope it'll be the first in a series that we will be running. For those of you who don't know the European Health Management Association, we are a not-for-profit network of educators, researchers, managers, and healthcare professionals, and we're focused on enhancing capacity and capability to deliver effective health and social care. So we're very much about excellence in healthcare management. And we've set up these webinar series in order to give members and our wider network fresh insight into effective practice in healthcare reform and centrally healthcare management within it. And I'm very happy to be able to introduce Dr. Antoni Peris, who is a EHMA board member and also chief executive of CASAP, which is widely regarded to be one of the most innovative primary care services in Catalonia. As I say, this webinar series is not just a sort of chalk and talk. We're going to set it up as a conversation, giving hopefully you an insight into current innovations, and also giving you the opportunity at the end of our discussion to be able to ask questions yourself. So, welcoming you, Antoni, and just to kick us off, to be able to ask you to give a short introduction to maybe the structure of healthcare in Catalonia as a backdrop to the work of CASAP.
Yes, Catalan health system is based on a difference between providers and a financer. We are under a public system, a public health system, just like the rest of Spain. But in our situation in Catalonia, there is not a single provider, but many different ones, both for hospitals and for primary care. As a matter of fact, most of the money comes from taxes. Taxes go to Madrid. Madrid gives us to Catalonia part of them. And it's not a finalist, as to say, income of money, but it's a Catalan government who decides how much of that money is allocated for health system. Then it's the Department of Health through a specific branch that's called Catchup that hires the different providers. As for primary care, it's approximately 75–78% that is managed by Catalan Health Institute. That would be the equivalent of administration itself. So all professionals working for Catalan Health Service, Catalan Health Institute, sorry, they are civil servants, both in primary care and a hospital. Nevertheless, there is another part, around 20% of population, that is attended for secondary level hospitals, mostly out of Barcelona, and for primary care, both in Barcelona and out of the capital, by different organizations. A few of them private, most of us public, that provide this service. Professionals are hired under a labor contract, and we work to provide these services.
That's really helpful, Antoni. And I mean, CASAP's been around for a dozen years, slightly more than a dozen years, providing sort of network primary care services within Catalonia. Can you say a little bit more about the actual services it provides and who it provides them to?
Yeah. Structure is geographical. So every primary care team, because we are organized through teams or around teams, it's covering a population that runs, depending whether it's a rural area, from mostly 10,000 people to 30,000 people as a most, officially. Nowadays, CASAP is running two different units. One of it is primary care emergency unit, and that covers for around 135,000 people from 3-4 different cities. And we run also, and I'll explain mostly about this experience, a primary care team that covers around 32,000 people. This team is called Campbell, and the main objective we have is to give every sort of health services. Meaning by that, we're responsible for diagnosis, we are responsible for treatment, we're responsible for follow-up, for promotion, and for prevention also. The population comes to us and may be attended on basis of a scheduled consultations. That's the most desirable, of course, but many population, both children and adults, are attended through what we call spontaneous demand. They may contact us online, on internet, and ask for an appointment with their nurse or doctor. They may come to the center itself, or they make a call. Then we decide whether this call, whether this demand of help may be attended or is to be attended immediately or may be delayed on time. Every nurse, every doctor has a list of assigned patients, but we are under salary. We don't get the money, we don't get our specific income as professionals from the amount of visits. We don't get it from the list itself, but the list have been rising, and so far doctors attend around, or have enlisted, not attend, around 2,200 people. As for pediatricians, that goes down to 1,500. And the most important difference with other countries in Europe is that we work under the idea of interdisciplinary teams.
And do you feel, Antoni, when you talked about some of the drivers and some of the similarities to other health systems and some of the differences, and then link that, you've got the services and then the importance of interdisciplinary care. Can you really talk about there being a sort of CASAP approach? Do you have a distinct approach? And if you do, how would you sort of explain the essence of it?
Yes. I mentioned we work in a team. I mentioned also all the activities we do, but we are not superhumans. We don't fly, we are not that strong, we cannot solve anything or have X-rays to evaluate the things. But we are professionals. It's not that different with other teams in Catalonia or in Spain. Most of the teams are constituted by this ensemble of professionals. But what we have been working is that this team can go under a specific strategy, under a specific, following specific philosophy, it's to be interdisciplinary. We look from a managerial point of view to change it all and to look for all the advantages that could that could give us the different the different levels. What did we think of when we started? We thought of gate opening. There is a gatekeeping system all over Spain. People may go directly to the ER room, either if it's primary care or hospital. They may also go directly for women's care or gynecologic services. But if they want to go to some specialists, they are to be first attended by primary care specialists. That's us. Nurses currently are developing a specialization in primary care, but it started just 6 years ago. There is no difference like in other countries in Europe, mainly the UK, with the advanced nurse or the consultant nurse or so on. They have all the same degree so far until these 3 years. The doctors, on the other hand, I was in another life, specialists in family and community care. So the idea is that we attend all these demands, analyze what the patient needs, in which situation the patient is, and we are taking him or her by hand to solve this situation, either in the same team, either asking for tests, either referring the patient to another level when it's really needed. But what we had been working since we started was the concept of subsidiarity, meaning we are different professionals, different group of professionals. Everyone must develop their abilities, must develop the fulfillment of their knowledge, of their skills. So what we promoted was this skill mix. Everyone has a basis according to the university career or the postgraduate studies, but we tried to look for the maximum of these abilities. So if there are clerks also in our team, they are not just to answer a call, but evaluate what is that call for, meaning they are to know what are the different pathways inside the team, and they are responsible for taking these patients' needs to a different professional. Maybe it's best for them to be attended by a nurse, maybe it's best for them to be attended by a doctor, maybe this demand may be attended immediately or may be delayed. The clerks are not making any diagnosis at all, but as a matter of fact, they are taking the patient to the door, to the professional who may ask. How did we evolve with it? With training. Training, it's not a mere comment. It's not just because we provided them with one or other courses, training courses, but we look for what our population needed, and we look for the courses that best suit the needs and the knowledge, the pre-existing knowledge of our professionals. We cannot, by law, increase a lot our professional salary, but we may increase a lot the investment in this training. And we have been doing this since we started 12 years ago.
It's fascinating. I think that notion of gate opening rather than gatekeeping is pretty meaningful, because that gatekeeper is very much about, in a way, stopping, blocking, rather than the gate opening, which seems much more facilitative. But I won't pick up on that. I was going to pick up on evidently the role of training and trying to the subsidiarity. Could you give us an example of how nurses are empowered to be able to take responsibility in a way that they might not traditionally do?
Yes. For instance, for many years, all the demand went to doctors. What we wanted was this demand to be distributed, not just for doctors, but for other groups of professionals. Some of the demands are to be attended by nurses, some for the odontologists, some others are to be attended by social worker or midwife. What we pretended to work on was mainly for this acute demand. Since many years ago, in Spain, it's been already nurses who've been taking care of chronic patients, meaning by those hypertensive patients, diabetes, hyperlipemia, obesity. But in the same way that primary care has been taking responsibility and responsiveness also for all these chronic patients that were 25 years ago attended in hospitals, we wanted also that nurses take care for many situations that previously were taken care by doctors themselves. So in this way, we identified different situations common in our setting that could be attended by nurses. Who decided that? The group itself. So we organize a working group with nurses and doctors. We look what was being attended in some walking centers in UK or in Australia or Canada, where they have been developed, and decided which situations might be solved autonomously by nurses in our setting. Once they agreed on a certain list, then we evaluated the nurses' knowledge or nurses' skills, and then we looked for training for those skills that were not completely fulfilled. So it was either the doctors in the team themselves that trained the nurses, or nurses who came from other teams or from hospital itself. For instance, we planned that the nurses could identify a normal electrocardiography, not to make a diagnosis, but to evaluate if it was normal or not. So there was a training made by nurses and doctors on the other nurses to make that. The pneumologists from the hospital came and made a training on pulmonary auscultation. The nurses are not making the diagnosis whether there is a pneumonia or asthma or whatever, but they know to make the difference between normal and abnormal. And on the long run, they even identify or can orient the patient and telling if it's something specifically pneumonia or short of breath means really an infection or is a problem related to asthma. So we started with a short list, around 12 situations, and so far it has been more than doubled, because they show that they could really be responsive for many other situations. And we went from the sprained ankle or the rash or the burn in the leg to the flu, to low back pain, to anxiety disorders, for instance. And the result has been really satisfying, both for the population themselves, but also for the professionals, because in this way we make them to fulfill their own expectations as professionals.
And I mean, it's fascinating, Antoni. It's very impressive to be able to see the sort of momentum it's generated. That you're moving into more and more areas. And I think the other thing that I sort of pick up is this combination of very team-based. It's a very the collective decision to be able to agree what areas are best treated by which healthcare professionals, and this reference to effective practice to be able to draw on examples from Australia or the UK or elsewhere. Did you feel, though, as your interprofessional teams sat around the table, were there differences in terms of reluctance or interests? Did you find more groups were initially more committed, others were less committed, or did you find that they were all quite equal in terms of how much they supported this as an approach?
Yes, one of the difference between CASAP and Catalan Health Institute, as I mentioned before, is that we are not, we are under salaried also, but we are not civil servants. So the importance is not the amount of money we may get as an organization, it's not the amount of the salary, but the importance is that we may choose the professionals. So when making the selection for these professionals, we offer them this training I mentioned before, but we ask them for if they are in the thinking of interdisciplinary on one hand, and this professional development. So as a leaders, the vice manager myself, who've been working since all these dozen of years together, we've been offering all the professionals who wanted to get aboard, as to say, this professional development. And we have been asking already from the first moment for this commitment. Everyone here, except me, except myself, is quite young. So the level and the knowledge is quite similar. We look at for some specific abilities in some candidates to cover areas we had not covered previously, but when mainly we look at the attitudes. You can provide more knowledge, you can provide developing skills. Attitude is difficult to change. So from the first moment, we ask them if they want to come with us with this idea on mind. Of course, once inside the team, some of them don't consider at all, or not at all, completely interdisciplinary, and still make the point that they are doctors and doctors' role. So, sort of. We are to work continuously on that. That is heterogeneous. It's about 14 doctors nowadays, and 8 of them are working with us, or 10 of them since 8 years ago, 9 years ago. So the people is quite stable in spite of they might have left to look for other chances. As for the development of the project, maybe for some situations, some doctors may be reluctant, but some nurses may be reluctant too, because of being afraid of having too much workload. But nevertheless, most of the team, I want to be glorious telling everyone, but most of the team have fully cooperated in one moment or other, at least, and a big part of it has been interested on being themselves developed completely as professionals.
You can really see the benefits of it, and I think the honesty when you say that sometimes there's a sort of reticence, sometimes there's a reluctance, but that people are contributing. One thing I just wanted to pick out was how you address risk, because that's something that quite often when you're looking at restructuring services, risk comes up and risk assessment comes up.
Yes. Well, there are two sorts of risk. One would be the clinical one, of course. The other one is the stability of the team, and this could be linked to the administration itself. I'm the manager, but I under a board that may decide to change the strategy. As you may say, for the most risky bet we took was from the beginning the nursing intervention in acute situations. The accuracy of the health clerks referring the patient to a nurse or to a doctor was very high, around 90%. This was a study we took 3 years ago that's been published, and it was around 450 patients, I think. So the amount of is quite significant. As for nurses' autonomous resolution, according to our guidelines, you saw in the previous slide, is 74%. Nevertheless, some of them took a resolution further than the guidelines demanded, and it went up to the 80%. The average waiting time is 9 minutes. So that means that the population may be attended faster than when asked in a different way. What happened with the risk? Nurses are fully satisfied. The population has shown also to back it completely. We have not had any complaints, except for 2 of them, where the patients didn't agree to be attended by nurses. 2 of them that were doctors who came as patients and disagreed with it. And as for the board, has been fully satisfied. We have not worked in the sense of using nurses' abilities to have a group of professionals who get a lower salary. Of course, nurses have a lower salary than doctors, but this has not our goal. This has not been the reason for starting this structure. Our idea is that even if this strategy may be a shortcut that many patients took an advantage to avoid delay, short or long, in doctor's consultation, it must be used, and it is, by nurses themselves to identify those areas where health promotion must be developed in certain patients. Of course, when a young people comes because he has a bruise, he has a burn or some sort of wound, you cannot develop completely all the health promotion package. And you can sometimes to get somebody to get inside it, because it's this group, young group of population, who rarely attends spontaneously, otherwise, the doctor's office. And also there are some chronic patients who attend this pathway, where the nurse can also make a follow-up on their glycated hemoglobin levels, or whether the echocardiography, ultrasound, cardiac ultrasound has been performed because it's a heart failure patient, or so on. So it's been used also to catch some of these patients that otherwise would be out of the radar, as to say.
And with the patients, you know, you've talked about potentially reduced waiting times. You've talked about some other benefits, but what's been your experience of both the positive side and maybe some of the not so positive side about how patients have experienced maybe seeing a nurse when they were expecting to see a doctor, maybe spending more time with the clerk explaining what their challenges were before they were referred on to a nurse? How did you also involve them in the process, and how have they responded to these changes?
Yes, maybe it's quite small, but when we make a difference between different situations. One was the real emergency, one was the sort of situations where the patient should be attended by nurse because it was to take care of a wound or a sore or whatever. The other ones were clearly specified when was the nurse to take care of the patient, when was the doctor. In the first years, we had some trouble when the patient was referred to the nurse. She couldn't solve the situation, and the patient was to go to visit the doctor, and that meant an hour delay. It was a real problem because we hadn't properly designed the pathway. So we were to work on it. And this working group that started all these pathways has been still working till now. So maybe someone has changed, but there is still a couple of clerks, 3 nurses, a couple of doctors, who have been analyzing the incidents. So as when some situation, different times, makes the patient to be first attended by nurse, but afterwards he's to be referred or she's to be referred to doctor, in those situations, we then change, we move the pathway, and we move the situation to the other column. So as the patient would be first time attended by doctor and not by nurse. This was the main concern we had. It happened for a couple of years. Then when we introduced other situations that might be attended autonomously by nurses, it happened in one of them again, and we were to change it again for doctors.
And have you monitored patient satisfaction with these new pathways?
Yes, we did it. I don't have the slide here about that, but the satisfaction was high. We always make clear that it's a nurse who's attending the patient, not a doctor. They know it. And when they insist on, no, I don't want a nurse, I want to speak with doctor, it happens very rarely, but when it happens, the patient is enlisted, appointed with the doctor themselves. We make also an evaluation of how do they feel about being firstly triaged by a clerk, and the result was real high. And as for the care of doctors and nurses, we asked them what do you think, if you had another time suffering from this in this situation, who would you prefer to be attended by? A doctor, a nurse? I don't mind. The surprise was when they could choose freely. It was just a survey. The answer of doctor was around 40, but the answer of I don't mind was over 50. So less than that, because it was, I think, 30-something for doctors, 20-something for nurses. It was more doctors than nurses when choosing, but it was more than 50, or around 50, when they said, I don't mind. So that's important. We identify in primary care that for some people, mainly young people, accessibility and being fast attended is more important than longitudinality. This is real. For people who have been attended by us many times, and of course for chronic patients, longitudinality is very important to have an overview or holistic view on their situation. And for small things, people really want to come and go fast.
And that's very clear, Antoni, and that gives me a nice sort of segue into asking you, this approach seems very person-focused. It's very hands-on, and your team working. How does it relate to the digitalization, to the digital health agenda?
Well, we work on electronic, and skip these ones. This is for pediatric. This is a similar schema. And as for digital agenda, there are three different things that I like to comment. On one hand, we work on electronic health record. This electronic health record is not ours; it's developed by the health department, but it allows not only the professionals to register the day-to-day notes, but to make a follow-up for the chronic diseases. At the same time, it allows me, themselves, every professional, both nurses and doctors, but also myself as manager, to make a follow-up of the performance of every professional. Meaning on prescription on one hand, prescription related, for instance, to hyperlipemia, hypertension, diabetes, on metabolic diseases, to see the level of control for according to glycated hemoglobin for the diabetics, or to evaluate if the heart failure patients are properly attended. This is really, really important. Since a couple of years or 10 months or so, we are able to look into a repository, not completely direct, but into a repository where we may look the hospital follow-up, both the discharge information and the daily informs for the patients that are in hospital, and also they can look at ours. On the other hand, virtual consultation dynamics has been growing, so as we make not refer the patient physically to the hospital, but may do a virtual consultation with hospital specialists. And also, we have created a virtual consultation where the patients themselves, who agree on that, may make questions to the doctors and nurses, or the professionals may send them both either a diet or a prescription or the comments or results of a test. We use SMS to make a souvenir of the next visits, and also we have been developing some other activities on digital field as Facebook for teenagers. Teenagers are reluctant to come. One strange thing in primary care in Spain is that in the teams, I went too fast, maybe most of us are primary care family physicians, but there are also pediatricians who take care from the children from the birth until 14 years age. From 14 to 18, when they are officially independent, it's the family doctor who takes care. From 12 to 17, from 12 to 18, this population is not completely follow up because of themselves. There are specifically set visits up to 14 years age, but not any longer. They may have doubts on sex, on sexual disease transmission, on birth prevention, on bullying, on many different situations. And we create this Facebook to make them aware of these situations. When they make a very personal question, they are answered by this character, Mark Castelldefels, to come to our team so they can be attended personally. But it has been quite successful idea.
And do you feel, I mean, there's a very interesting example of how you can take things forward, open it up, especially to younger people as a target group. Take us forward 3 years, 5 years, Antoni. What types of things are you thinking of developing? How do you feel CASAP services will evolve?
There are two sorts of activities. On one hand, I mentioned all nurses activity, but it's very important this service basket that we have widened. We took many patients that were before attended in hospital. Nurses have been attending these patients, both either if they are chronic ones or they have acute demand. That means that all the team, both nurses and doctors, have ability, have time to develop other activities. For instance, doctors may ask for diagnostic tests that are not in our setting, but that previously meant the patient to be referred to the hospital. Doctors nowadays ask for a magnetic nuclear resonance or a cardiac Holter or whatever test they consider they may need to make the diagnosis. On the other hand, we do have in our team a blood pressure Holter. We have an all-Mydriatic retinography camera for the diabetes patients. We perform allergy studies with a pre-test and so on. We have ultrasonography. So not every doctor does this, but we identified in the team, as I explained before, the abilities, the interests, the skills, the things that might be interesting for each one of the professionals, and that might be a benefit for the population. For instance, the allergy studies was taken care by a pediatrician, but before he retired, it was a family doctor who liked it and started. So it's one of them who can take care of the whole population, performing some activities. And we still are looking around that. Ultrasonography has been taken care by 3 doctors, and we expect this to develop further. We have a minor surgery. It's 2 doctors who work on it and 2 nurses, but these 2 doctors were later interested on dermatoscopy. So the idea is to take as much as possible. I think we've got already getting to the top, but as much as possible, the capabilities of primary care. And the most important probably is not just a clinical one, but it's in the between clinical and social one, that it's community. And as for community, we have been developing the Connected project that looks for elderly, mainly people who are lonely, people who are not ill, not necessarily chronically ill, maybe they are, but their main problem is to be lonely, to be alone at home with no relatives, with no friends, people who may have a fragility soon, and we want to look for these people to offer them what's called social prescription. In this case, It's not just the doctors, it's not some doctors, but mainly nurses who work on this project, and that's important, the clerks, who have been identified not just as agents for developing it, but agents who receive and who can identify these patients or these people that are not still patients, but they are in these situations at risk. So I think we are working further on diagnose, but we are working further on community.
And that really is, you know, you're painting a very rich picture of how primary healthcare can develop and is developing going forward. We're going to, if there are questions that people would like to put to Antoni, then if you type those into the chat box, then we can I can put those. But as I sort of ask you to do that, just sort of drawing it to a close, is there what would you suggest maybe has been the single most important factor that's helped you to achieve what you've achieved as a team?
I would say that the most important is commitment and leadership. It's really basic to choose the professionals, that's for sure. But the idea was on our mind, on the vice manager and myself since the beginning. We had this idea in mind, and we wanted the primary care to be highly resolutive, to have a high responsiveness on every aspect. We consider that the hospitals have evolved towards third level, and the secondary hospitals need to be to perform a real lean strategy. There is a lot of activities taken care in secondary level hospitals that is to be taken care in primary care level, and that was our main idea. Besides that, of course, I think we've been lucky in getting an excellent team, and then the thing is balancing this responsiveness demand that I may do from the management with an acknowledgement that goes through P4P strategy, because P4P has not been lucky in different studies that say, okay, this is useless, it's not efficient at all. But the thing is that we have been moving from the control, the chronic patients control, to the abilities development, skill development, professional development, and has been great for the professionals because they develop themselves. It has been great for the team in achieving this level of responsiveness. This has been very, very useful for everyone, I think.
And that's, I think, in drawing, you know, our question and answer together, I think that when you say about being motivated, having the sort of energy and also having leadership, I can absolutely see that. I can see the leadership that you've offered, as well as leadership across the team that you work with. I've had one question coming through about mental health care, and talking about examples, say in Sweden, about being able to get access online as well as in person for mental health support. How do you tackle at a primary care level mental health?
Yes. One thing I don't like about Catalan health system is that primary care has been too much siloed, as to say, too many compartments. And there is the main network primary care, that's all the primary care teams, including family doctors, nurses, and pediatricians. But then there is a palliative care network, and also a women's care network, and finally a mental health care network. In our setting, in our surrounding, we've been working on that. Doctors have the full responsibility of making the diagnosis and the follow-up of mental illness. And we have consultancy twice a week in our team. One every Monday, psychiatrist is attending patients in our setting, and both Tuesday and Wednesday there is a psychologist. So we can set some sessions, formal or informal, depending on the week, with both of them or each one of them to make consultant on doubts. Then there are specific pathways already predefined, so as when the patient shows up not to improve after some a month or a month and a half treatment, the patient may be referred to a psychiatrist for evaluation. And finally, if there is a severe illness, a severe mental illness, it's the psychiatrist or the psychologist who takes care of these patients to make the follow-up.
That's helpful. And I think when you were talking about there being additional silos to work on, that shows that, you know, the job is never done in a way, that you always need to be able to take it to the next level. That's very much the nature of primary care. Anthony, we have a question. Luis Navarro, I think. Luis, do you want
yes.
to?
Okay. Hello? Can you listen
Hello?
to me?
Yes.
Well, hello everybody. Hello, Antoni. Thank you for your presentation and for your work there. It's amazing. And as you know, we have been following each other's work, so we know about this. But I want to say a couple of things. First, in Portugal, we have about 70% of our health centers very similar to your center.
Mm-hmm.
I'm not saying they are equally sophisticated as yours, because you are an exception, but we have probably 2 or 3 in Portugal that are very similar to your case. And saying this, I think we should have numbers. We should have more, because we need to start comparing real things. When you mention, for instance, gatekeeping and gate opening, what this means? I know what it means, but what it means in terms of numbers, in terms of actions. What is the difference actually that are happening there? Because here we also can call it gate opening, because it's the primary care physician that sends the patient to the hospital. So we need to really understand what this means in order to have a clear picture, and if you want to define new policies to improve the communication between and the integration of care. Secondly, I was really impressed because you mentioned you have a lot of exams. You have there in your institution, you have the exams there, the ultrasounds, the allergy, the diagnostic. Are you having the technology there with you? Because that's very important, because we are discussing here in Portugal that we should have that in the health centers. But people are discussing about the benefits, what are the costs, what are the benefits. So I think if you have numbers, that will be very wonderful, because then we can compare and we can decide and look for new perspectives. Thank you very much. It was a pleasure to listen to you. I hope to see you again in Hungary.
Yeah. Yes. As for the test, we do have the anticoagulant level blood test. We do have the dermatoscopy, the ultrasound, and the prick test. All of the minor surgery that we refer after the sample for the pathology analysis. All those are in our team. And I agree, we need numbers. The issue is when comparing around Europe, it's very difficult because the systems are different and the teams are different, or in many countries there are not even teams. And there has been very, very interesting comparisons like FAMEO, for instance, But when you go further inside, when you want to compare, it's quite difficult. When I speak about the gate opening, I mean resolution, I mean responsiveness. And in that sense, I would compare the different teams or the different country systems, asking which activities are performed in the primary care team whenever it's performed by either if it's by nurse or if it's by a doctor, or is it referred outside to the hospital. I complain about this women's care taken away, because that happened when I made my specialty many years ago. It was taking place in the primary care team, and they took it away. Okay, things have changed, and now we may compare with France, with Portugal, with UK, and we realize that this women's care in other countries is taken care by primary care doctors. Nevertheless, our path took us other way because of political reasons or because of lobby reasons of gynecologists or radiologists or whoever, and take us to catch the fish from the hospital, as to say. So it's important nowadays see how many morphine is used in primary care to attend the palliative patients, how many domiciliary care, home care is done, and how many treatments are used to make the heart failure patients to lose weight, to eliminate liquid from them, how many halters, how many treadmill tests are asked by doctors instead of referrals to the hospital. Of course, this is also linked to the financing and the purchasing system of existing in the health system. If the hospitals get the money, primary care does not, there is no incentive for primary care for developing this complete responsiveness. And this is also something that goes beyond our possibilities. But if we want to compare how do you work in Portugal, how is it in France, how is it in Switzerland or Italy or in UK, I think it's quite easy if we set some indicators such as percentage of referrals related to attended population, percentage of referrals for certain reasons or for certain specialties, and which tests are performed specifically in primary care. And that might be really useful. And I don't know if from EHMA we could develop a working group inside the primary care SIG to develop that.
Yes, that's a perfect lead. I'll just come back to that in 1 second, Antoni. I've had another further question, and we just have a couple of minutes left, so a very quick answer if I can. It's a congratulations, thanking you for your lecture. Asking about additional services, dietetic, physiotherapy, whether those are provided, whether you use regularly organised protocol-based health status assessments as part of the services you provide.
Sorry, it was cut in a moment. You mean for physiotherapy specifically, or?
Do you have, yeah, so first of all, do you have dietetic and physiotherapy services within?
We don't. There are no such in primary care. Dietitians are in hospitals, and primary care physiotherapists there are, of course, but they are out of primary care teams. And the ratio is real low. It's a shame, the ratio we have in our area. So the delay in care is very important. We do have a specific way of evaluating the needs of the patients to refer to them.
That's fantastic, and we're just drawing to a close. So I think at that point, say thank you very much, Antoni, for taking the time out of, we can see a very busy day job being able to run services at CASAP. This is the first of a series of webinars, as we've said, that EHMA will be running, and we'll be running The next seminar we'll be running will be on integrated care services, so we will be advertising that quite shortly. And also, as Antoni said, Antoni is chair of our special interest group on primary care, which meets in person at our annual conference, which this year will be held from June 20th to 22nd in Budapest, Hungary. But also we connect up, the SIG connects up online, and if you're interested in getting involved, then please do drop us a line, and we will send you on details of how to do that. And if you'd like to get involved with the primary care special interest group, I think that idea of being able to look at a common set of measures to be able to compare between Portugal and Spain and between a whole host of other countries, I think would be a really helpful thing that EHMA could possibly work on in terms of being able to look at next steps. But other than that, thank you all very much for your attendance and your contributions, and thanks once again, Antoni, and look forward to seeing you all at the next EHMA seminar.
I hope so. Thanks to you all.
Bye-bye.
Bye.